Okay, so we're going to do the heart review now. We'll go through the first part, the external anatomy. For the external anatomy, you need to know the two layers of the pericardium. The layer that is touching the surface of the heart is the visceral pericardium. It is fused with the epicardium, which is the outermost of the three layers of the heart. The other layer that you actually see that you would have to cut through if you were going to do surgery and open up the chest and see that the heart's contained in a sac, that is the parietal pericardial sac. The surface of the heart features that you should know. If you're looking at the heart, the first feature that you would want to identify would be the pulmonary trunk. It's going to be the most anterior of the great vessels. Once you see that pulmonary trunk, you can then have identified the anterior surface of the heart. Immediately behind that would be the aorta. Now that you would know front and back, you should then be able to identify the right atrium and the left atrium. And then the location of the right and left ventricles. You should then also identify the pointy inferior portion, which is the apex. You should be able to see the vessels that are bringing blood into the right atrium, namely the superior vena cava and the inferior vena cava. And the left atrium, the vessels leading to that, are the pulmonary veins. On the posterior aspect of the heart, you should see the coronary sinus. The coronary sinus is a large, this looks like a large wide vein because all of the veins of used up blood from the heart are draining into this coronary sinus, which then delivers blood straight back into the right atrium. You'll also see coronary arteries. But on the hearts that we've dissected in class, you won't need to identify them on that. There'll be images of the heart for the online students that you will have to identify coronary arteries. The muscular layers of the heart has three main layers. The outermost layer is known as the epicardium. It is fused with the visceral pericardium. Then there is the myocardium. It is the vast majority of the heart tissue. It is the contractile cells of the heart. Then the innermost layer that's actually touching the blood, that's lining the chambers, is known as the endocardium. Next, we'll go through the coronary arteries. The only coronary arteries that you'll need to know are the right coronary artery. The right coronary artery really just serves the right side of the heart. So that one's as straightforward as it can be. We're not going to learn any of the smaller arterial branches from there. Then we have the left main coronary artery, and that doesn't serve any specific one region of the heart. It divides immediately to become the left circumflex artery, which will bring blood to the lateral portion and posterior portion of the left ventricle. The left main coronary artery will also divide into the left anterior descending artery, most commonly referred to as the LAD. Some textbooks are more frequently referring to it as the anterior interventricular artery. This will serve the anterior surface of the left ventricle. So of these three arteries, the right coronary artery, left circumflex, and the left anterior descending, you are responsible for the region of the heart that it will deliver oxygen to. You also should know that the left main coronary artery, that as well as the right coronary arteries, are the two branches off of the aorta. The left main is just a centimeter or two long before it divides into these two. The drainage of the used up blood from the heart will come back through the coronary veins. I don't have you know any of the specific coronary veins that we have. Just know that all of the coronary veins, all of the deoxygenated blood from the heart return to the coronary sinus, and then that has an opening directly into the right atrium. The internal cardiac anatomy. You should know the 4 chambers of the heart: right atrium, right ventricle, left ventricle. The left ventricle will have a very, very thick wall because the left ventricle ejects blood to the aorta and out to the whole body. So it requires a greater amount of force than the wall of the right ventricle, which sends blood a very short distance to the lower pressure lungs. So the wall, visually, you can identify the left ventricle by the vast thickness of the musculature that makes the ventricle. Between the atria and the ventricle are atrioventricular valves. So they divide the atria from the ventricle. We have a right atrioventricular valve, and we have a left atrioventricular. These also have other names. The right atrioventricular valve is also known as the tricuspid valve. The left atrioventricular valve is also known as the bicuspid valve. The left atrioventricular valve, also known as the bicuspid valve, has a third name known as the mitral valve. These valves have features inside the ventricles. There'll be portions of musculature that come up from the ventricular walls that will attach to strings that go to the flaps. The strings are known as chordae tendineae, and the muscle portions that come up are known as papillary muscles. You will see them both in the right ventricle as well as the left ventricle. These features, chordae tendineae and the papillary muscles, are exclusive to the atrioventricular valves. So the pathway of blood flow is such that blood from the inferior vena cava and superior vena cava enter the right atrium. Comes in, this right atrioventricular valve will be open, so blood will continue into the right ventricle. This blood is deoxygenated. It is the used up blood that is just returning from the upper and lower body. The right ventricle, when it contracts, it will send blood out of the right ventricle, out through the pulmonary trunk to the right and left pulmonary arteries to the lungs. That blood will get oxygenated and return back to the left atria via the pulmonary veins. That will be open. Blood will go down into the left ventricle. When the left ventricle contracts, it will squeeze and send blood out the aorta and out through the whole body. The left side of the heart will have oxygenated blood. So the 2 valves that we've already done, the right and left atrioventricular valves that are within the chambers of the heart. To prevent backflow back into the heart after the ventricles have ejected blood out to the lungs or to the body, we don't want that blood to come back. So when the right ventricle ejects blood, it pushes open the pulmonary semilunar valve, and when the right ventricle relaxes, blood won't come back into the right ventricle, but will shut that pulmonary semilunar valve. The left side is contracting, the left ventricle ejects blood out across the aortic semilunar valve when it's wide open, and then when the left ventricle relaxes, that aortic semilunar valve will shut. Both the pulmonary and aortic semilunar valves have no chordae tendineae, and they have no papillary muscles. They're only the cusps. And the closure of those valves will also make a sound. So the heart sounds are because of valve closure. The timing of them would occur first from the 2 atrioventricular valves slamming shut at the onset of ventricular contraction, And then you'll have another heart sound with the two semilunar valves slamming shut at the end of ejection. For electrophysiology, we're going to talk about electrode placement. We will not be doing the chest leads. The placement of the electrodes, we have one on each shoulder and each hip. It could be extrapolated to each wrist and each ankle. It essentially makes a box around the heart. The one at the right hip is a ground and is not used in the three main leads that we will be talking about. So the lead in this context is a pair of electrodes. Lead 1 will be about, for instance, from the right shoulder to the left shoulder. That would be one lead. And lead 2 would be another pair, and lead 3 is another pair here. So the placement of these recording electrodes are such that it will surround the heart so it can detect electrical activity or electrical waves that are traveling through the heart. It's picking them up. It detects if you have, say, a negative electrode on this side and a positive electrode on this side, and we have the heart. This is my hideous oval heart here. If, in this case, the sinoatrial node, you have depolarization across the heart in this direction, it's going towards a positive electrode, so you're going to record it as a positive blip. If you were to have a repolarizing, which is a negative wave going to a positive electrode, you would have it as a negative deflection on the chart paper. If, for instance, you're traveling down the interventricular septum, if you still consider this side as being positive, you're still getting closer and closer to the positive side, so you're going to see that as a positive deflection or a positive wave. You will need to know the conducting portions of the heart. Where is the pacemaker? What is the pacemaker of the heart? The pacemaker of the heart is known as the sinoatrial node. Sinoatrial node is in the upper back wall of the right atrium. When it depolarizes, it initiates the electrical signal, and that wave will depolarize the right atrium followed by the left atrium. So it makes a nice right to left wave or progression of electrical depolarization that will be picked up on by your electrodes. The backup pacemaker is known as the atrioventricular node. It is located at the bottom portion of the right atrium, right in conjunction near the top portion, the top narrow portion of the interventricular septum. So it acts as a relay station to bring the depolarizing impulse that's within the atria down into the one electrical region that the electrical pathway is allowed to go to, down into the ventricles. So the atrioventricular node is also considered the backup pacemaker because if the sinoatrial node is not working, the atrioventricular node is able to initiate a beat. It then goes down the bundle of His, which is in the upper narrow portion of the interventricular septum. Then it goes into, it splits down because where the interventricular septum gets very, very thick, it has to have two separate electrical pathways. So you'd have a right bundle branch and a left bundle branch, ultimately going down to the apex, back up the interventricular septum and around to the outer free walls where be Purkinje fibers. Those are the ones that are actually getting the myocardial cells, the contractile cells, to actually get them to initiate a beat. These others are more just like a wire pathway going down. So they're not activating the adjacent muscles. It's really the Purkinje fibers themselves that are causing the activation of the cardiac muscle. So now that we know the pathway, the electrical pathway, and you should be able to identify these on a diagram. Once we know the sequence of what's happening through the heart, once we know the sequence of what's happening in terms of depolarization order, then we can interpret the electrocardiogram. So when the sinoatrial node depolarizes the right atrium and then the left atrium, we see that as a positive wave known as the P wave. The P wave represents atrial depolarization. The electrical signal gets to the atrioventricular node, travels straight down that bundle of His, the bundle branches going straight down the intraventricular septum. So we're going to see this as it's going up to this spike, back to the bottom of the apex, and back up and around to the ventricular free walls. That is going to be known as the QRS complex. So that represents ventricular depolarization. Depolarization is not contraction. Depolarization is the signal to cause contraction. So the contraction event happens after depolarization. In fact, it happens during the flat line here. Then when the ventricle is relaxing and repolarizing, we would have this T wave. This represents ventricular repolarization. So you should be able to not only identify the regions, the electrical active regions of the heart, sinoatrial node, atrioventricular node, bundle of His, right and left bundle branches, and Purkinje fibers, and knowing that sequence, you should also know about the P wave, what the QRS complex, and the T wave, what each one of those represents. P wave is all about action, depolarization, the signal to tell the atria to contract. The QRS is the signal, the depolarizing signal, the activating signal, if you want to think of it that way, of the ventricles telling it to contract. And then the T wave, repolarization, a rebalancing of the ions across the membrane of these cardiac myocytes. So the P wave is an electrical activity, but the action, the atrial contraction happens after. QRS is ventricular depolarization, so the actual contraction of the ventricles is happening after. So we'll finish this electrical portion up with a little quick review of the cardiac action potential. So if you recall, the action potential, we measure them in millivolts. A resting membrane potential is very, very negative. When a cell is going to depolarize, so if we have this here as a cell, cardiac myocyte, it's normally very negative inside compared to how positive is on the outside. On the outside, we have loads of sodium. On the inside, we have lots of potassium. There's also potassium outside, and there's also sodium inside. But the higher concentration of sodium is outside, higher concentration of potassium is inside. When a cardiac muscle cell is normally at a very negative level, minus anywhere below minus 70 to minus 90, in fact, when sodium channels open, sodium will enter the cell and make it very positive. So if we're looking at a chart, we can see this, it becoming going away from negative. So it's becoming more and more positive. This is known as depolarization. It's due to sodium influx into the cell. At the peak, at about plus 30 millivolts, the sodium channels will close and no more sodium will enter the cell. And now the cells are very positive. The cell wants to become more negative. So the cell will open up at plus 30 potassium channels and let potassium leave. When potassium leaves, we see that we start to repolarize. In a neuron, potassium would continue to leave and the repolarization would bring the cell back down to its normal negative resting state. But since we're talking about cardiac cells, a little extra thing happens. Is at the same time that potassium is leaving the cell, we open up calcium gates and we actually allow calcium. Calcium is a positive ion. So you have a positive ion potassium leaving, you have a positive ion calcium entering the cell. So the two positive ions are crossing, and so they are not making any net voltage changes. So during the time that calcium is entering the cell, potassium is also leaving the cell. So the voltage does not change. This is known as the plateau phase. Finally, calcium channels close. No more calcium is coming in, and therefore the potassium that's leaving is then able to bring the cell back to negative and cause repolarization, which is potassium efflux. That means potassium exiting the cell. So this plateau phase is unique to cardiac cells. The reason for this is that it causes the action potential to be of such a great duration that it forces the cardiac cells, when they contract, to allow them to have a relaxation, initiate a relaxation phase before another contraction is allowed to come. That is not the case for nerve stimulation of skeletal muscles. We want to have contractions. If we want to hold something steady, we're going to hold, say, this microphone case right here in my hand and not just be twitching it. We want to hold it steady. So I would have a nerve impulse coming down to my bicep over and over and over again to maintain a steady state contraction. We never want our heart to do that. Never. So we never want our heart to just squeeze and beat and just keep squeezing. So we want relaxation to occur. By having this, no matter how quickly our heart may be being stimulated, it will not be stimulated more quickly, more rapidly to allow contraction. It will actually force a relaxation between each one. Okay, for the cardiac cycle, let's just do this one real quick. You should be able to draw the cardiac cycle. You'll be given a wave, say one that looks like this. What wave would this be? This one is pressure of the left ventricle. It's going to be in millimeters of mercury are the units for this. So here we're going to start at 0. Let's label this. Put this here at 200. Okay. The easiest way to get through this drawing and to be able to draw other drawings, I'm going to ask you to draw the volume. I'm going to ask you to draw the electrocardiogram. I'm also going to ask you to do some calculations. So I'm going to give you a heart rate. Let's say the heart rate is going to be 60 beats a minute. Give you end diastolic volume is going to be, let's say, 150 milliliters. We'll have end systolic volume. Put that at 50 milliliters. Then I'm going to have you answer some questions. You're going to calculate this person's stroke volume. You're going to calculate this person's cardiac output. And you're going to tell me what this person's blood pressure is. We're also going to draw all the waves first. When I start this off, I'll do this. I'll look here and I'll draw the points on the graph that I know valve activity is going to occur. So there's going to be a dot here and a dot here. There's going to be a dot here and a dot here. Those 4 dots are representing valve activity. So let's name this first one. This one is going to be the atrioventricular valve is going to close. This one is going to be the aortic semilunar valve will open. This one over here is the aortic semilunar valve will close again. And then down here, we're going to finally open up the atrioventricular valve will open. Once we have all these valves figured out, then we can identify this phase. The phase between when the atrioventricular valve closes, but the semilunar valve is not open yet. So that means they're both closed. This is known as isoventricular volumic contraction. And likewise, from the point that that semilunar valve closes, but we have yet to open the atrioventricular valve again, this will be known as isovolumic relaxation. And it will be this distance. So we see them as going up and down on the pressure graph. However, on the volume graph, they will be flat lines. So let's draw the volume graph now. So if we do the volume of the left ventricle, and it will be in milliliters, so that's a volume. I'm going to draw these dots. So this first dot, I'm going to make a solid. This second one here, we're going to follow it down, and this would be an open. This one here, we'll follow this all the way down. This here, and this one, we'll follow it down. Open this. So let me erase my dots so that we're not overcomplicating this graph. So the distance, this isovolumic contraction phase, volume stays the same. So it's a flat line here. This isovolumic relaxation, even though the pressure is dropping significantly, the volume stays the same. So it also will be a flat line. The time between the two, this part of the graph, we see that here. This is ejection. Ejection of blood out of the heart is happening there. So that's this is what's going on here. We fill this in. So during this early part was the ventricle filling with blood. We have this little hump right here. That's the atrial portion. The atrial does an extra little squeeze, so a extra little hump of blood comes up there during this time. We then hit this first atrioventricular valve closure. That's here and here. Now no more blood comes in. The heart builds up pressure, but the volume stays the same, nice and flat, until the point that it opens the aortic semilunar valve. That's going to be here. And then now blood will be ejected. So there's going to be a great amount of pressure that pushes the blood out. We see on the volume graph this going down. Then that semilunar valve will close. Now the volume stays the same while the pressure is dropping. Atrioventricular valve opens, and then we refill it with new blood. Refill the ventricle. So on here, let me write our aortic. So that's our volume graph. Then let's write our aortic pressure. We'll go something like this. Comes down, hits the semilunar valve opening, rises with left ventricular pressure, drops with left ventricular pressure until the semilunar valve closes and the blood bounces off, creating this dicrotic notch, and then the pressure will then drop again. So this is our aortic pressure. As far as the electrocardiogram goes, right before this little hump here would be the P wave. So if we bring this up, we'll draw a P wave. Right at this junction where you see the AV valve closing is right where you're going to want to draw the QRS. From the peak of the ventricular pressure down to where it's going to relax, that's the only time that we actually have the T wave matching this distance. So we'll connect these lines, and now we have the appropriate timing for the electrocardiogram. So let's go to answer some of these questions. Oh, before we can, we need to label the volume. End diastolic volume, that's the end of diastole or the end of the filling phase. That is going to be the most full, match this up better, is going to be the most full that the ventricle is. So this is going to be our end diastolic volume, which we have 150 milliliters. Our end systolic volume, the emptiest the heart will be, that's going to be right down here. That's going to be 50 milliliters. So let's go over and we'll calculate stroke volume. Stroke volume is the amount of blood that the heart, when it's squeezed, how much it's sent out. So stroke volume is the mathematical difference between how full it was and what's left over. So in this case, the stroke volume is going to be 100 milliliters. The cardiac output is determined by multiplying the heart rate by the stroke volume. So we write 60 beats a minute times the stroke volume, which is going to be 100 milliliters per beat. Cancel out the beats and we end up with 6,000 milliliters per minute. You can also consider that as 6.0 liters per minute. That's the person's cardiac output. Now let's look at what's the blood pressure. Systolic blood pressure is going to match the top here. So in this graph, if this is 200, let's say it's 180. And the diastolic blood pressure is the point where the semilunar valve opens. So we'll bring this across here, and on this graph, it looks like it's 120. So you guys not too healthy, just blood pressure will be 180 over 120. So you should be able to identify all of these things from the cardiac cycle. You should be able to draw them. You should be able to extract information from these graphs and then calculate cardiac output. If you have any questions, then email me or Zoom me or let me know how I can help.